Hi students, today the topic of discussion is acute diarrheal diseases, otherwise known as ADD, acute diarrheal diseases. What do you mean by acute diarrheal diseases? It means increase in the frequency. So it is more of fluidic in nature, so more fluid rather than being solid. Second one is increased frequency. Second one is increased frequency. Increased frequency means more than 3 times a day. More than 3 times a day. So the stool output is increased fluid in content compared to the solid component. Second one is more increased frequency. That means more than 3 times a day. Acute diarrhea usually resolves within 7 days, a maximum of 14 days. A maximum of 14 days. If it is acute in onset, and lasting for more than 14 days, that is called persistent diarrhea. That is called persistent diarrhea. Acute in onset but lasting for more than 14 days is persistent diarrhea, whereas subacute in onset lasting more than 14 days is called as chronic diarrhea, which is generally due to malabsorption. So the definition is more than 14 days, acute onset, as well as infectious origin. It can be viral, bacterial, or something. Is persistent diarrhea, whereas subacute in onset, often non-infectious, is malabsorption, is chronic malabsorption. That is the difference that you need to know. Then one particular point is missing. What is that point? What is called dysentery? What is called dysentery? Dysentery is nothing but blood in stools. So let me finish here itself. So what is called dysentery? Blood in stools, called dysentery. Stool is called dysentery. So these are all the definitions that you need to know. Right. Now, what are all the causative organisms? Most common viral, and most common it is rotavirus. It can be also due to other virus such as Norwalk, Corona, everything. Okay. Adeno can also cause. But most commonly it is due to rotavirus. That's why rotavirus vaccine has been introduced by the national government. One, it can also be due to bacterial. It can also be due to bacterial. Most often it is in E. coli, and there are many types: enterohemorrhagic E. coli, enteroadherent E. coli, okay, entero-invasive E. coli. There are so many E. colis, bacterial. Apart from that, in immunosuppressed, you can get diarrhea due to cryptosporidium, or it can be due to CMV or Candida. Whereas Clostridium difficile Clostridium difficile is more common after using broad spectrum antibiotic. After broad spectrum antibiotic. Okay. And finally, dysentery, the most common cause in pediatric age group. It is not amoeba. It is not amoeba. It is not amoeba. In adults, blood in stools means amoeba. In children, it is always due to Shigella. Shigella, particularly Shigella flexneri. Shigella in India, Shigella flexneri. Whereas community outbreaks, outbreaks are often due to Shigella dysentery. Dysentery. Okay. So these are all the common organisms that can cause diarrhea, acute diarrheal disease. What happens in acute diarrheal disease? You will go for dehydration. You will go for dehydration. Why you go for dehydration? Because you lose your ECF volume. You use your ECF volume. That is the fluid that is present in the extracellular component. Along with that, you lose your sodium. Your sodium. Sometimes this sodium loss and ECF loss can be classified as three. One is hyponatremic dehydration. Hyponatremic dehydration. Second one is isotonic dehydration அல்லது isometric dehydration, and then hypernatremic dehydration. Natremic dehydration. What do you mean by that? So almost 45% is due to hyponatremic, 45%, another 45% is due to isonatremic, and another 10% is due to hypernatremic. So what do you mean by that? When you equally lose sodium as well as ECF, so you will get sodium loss, so you will get ECF loss as equal to sodium loss, is called isonatremic. When you have more sodium loss compared to ECF loss, it is called hyponatremic. And if you have more ECF loss compared to sodium loss, it is called hypernatremic. But majority of them are isonatremic and hyponatremic dehydration. And the signs and symptoms that were explained in that book are mainly holds good for hyponatremic and isonatremic. It is not for hypernatremic. Let me tell you why it is so. Right? Okay. So this is how you lose your ECF volume. Then comes your dehydration. How do you classify dehydration? Dehydration can be classified as some. Okay. Second one is no. Let me say no dehydration. So let me say green for no dehydration, and then yellow for some dehydration, and red for severe dehydration, and red for severe dehydration. So what are all the, how you are going to classify based on certain parameters? What are all those parameters? First one is general well-being, how the child's look. Second one is sunken eyes, sunken eyes. Third one is tears, tears, whether you get water from eyes. Fourth one is thirst, whether the child is able to drink or not. Fourth one is tongue, whether it is wet or dry. And finally, you have something called skin pinch. Skin pinch. You need to assess at least two of the above. No dehydration means what? No dehydration means despite loose stools, the child is not losing much of water from the body. So well-being means alert child. Any sunken eyes? No. Tears present. Thirst normal. Tongue wet. Wet. Skin pinch goes back slowly. Let me show you a demonstration. Goes back quickly. I am sorry. Skin pinch goes back quickly. So what is this? This is called some dehydration. And in some dehydration, only less than 50 ml per kg of water loss. Only 50 ml per kg of water loss from the body. And what is the treatment? Treatment is plan A. Plan A means what? You just give ORS. How much ORS you need to give? Very simple. Less than 2 years, 2 to 10 years, more than 10 years. Less than 2 years, 500 ml of ORS, blanket statement. 2 to 10 years, 1000 ml of ORS, and more than 10 years, 2000 ml of ORS. Oral rehydration solution. This is for some dehydration. Now let me come for, this is for no dehydration, plan A. Then comes for some dehydration. Okay, some dehydration means what? Well-being. Well-being means this is what? Drowsy. The child is hyper alert. The child is irritable. I am sorry, I can't say hyper alert. The child is irritable in some dehydration. Sunken eyes present, and then tears, some tears. Thirst, drinks eagerly. Drinks eagerly. The child, when you give more and more water, the child drinks and drinks. Tongue dry. Skin pinch goes back slowly. Goes back slowly, and it is less than 2 seconds. This is called some dehydration. This is called as what? Some dehydration. And what is the volume loss here? Volume loss is 50 ml to 100 ml per kg of volume loss. What is the treatment for some dehydration? The treatment for some dehydration is ORS, but it is not a blanket statement as we seen before, 500,000 2 liter. It is 75 ml per kg of ORS given over 4 hours. 75 ml per kg of ORS given over 4 hours. 4 hours. And then for each and every stool, 10 ml per kg of additional ORS. For each and every stool, 10 ml per kg of additional ORS. Now comes severe dehydration. Now comes severe dehydration. So what is severe dehydration? Here the child is lethargic. Sunken eyes, yes, present. Tears, no tears. Thirst, can't drink. Even it wants to, it can't drink because of extreme drowsiness. Tongue very dry. Skin pinch goes back very slowly. Very slowly. That means more than 2 seconds. And finally, this is called as what? Severe dehydration. Dehydration. What is the volume loss in severe dehydration? What is the volume loss in severe dehydration? The volume loss in severe dehydration is 100 ml per kg. So, what is the treatment of choice? IV fluids. What is the IV fluid of choice? You can use plain oral, you can use plain normal saline, you can use oral with 5% dextrose. All can be used, but don't give 5D alone. Don't give 5% dextrose alone. That is not recommended. What is the treatment of choice? As I told you, 100 ml per kg. So it is divided as 30 ml per kg fast correction and 70 ml per kg slow correction. If the child is less than 1 year, 30 ml per kg over 1 hour and 70 ml per kg over 5 hours. So totally 6 hours. If the child is more than 1 year, you can do still some fast correction. 30 ml per kg over half an hour and 70 ml per kg over 2.5 hours. So totally within 3 hours you can correct. So this is the treatment for severe dehydration. So some severe dehydration. Then comes about ORS. So fluids we had discussed. ORS previously, okay, before 2004, what we used is old WHO ORS that is mainly meant for cholera. That is mainly meant for cholera. So the osmolality is 311 milliosmol per liter. But after 2004, we came to know that it is most often due to rotavirus, and here less osmolarity is lost in stools. So what happens? We use reduced osmolarity ORS, that is called new WHO ORS, whose osmolality is 245 milliosmol per liter, and it contains sodium 75, glucose 75, and then what else you have? Chloride 65, potassium 20, citrate 10. Citrate 10. So 245 milli. This is new WHO ORS. New WHO ORS. That is what we are using right now. Why glucose? What is the role? What is the discovery of ORS? Very, very simple. Because you have something called glucose sodium co-transport. Glucose sodium co-transport. When you give glucose, one molecule of glucose, it will absorb one molecule of sodium. Along with that, water also goes in. So the mechanism of action of ORS is sodium glucose co-transporter. Sodium glucose co-transporter. That is very, very important. Glucose co-transporter. What is the drug of choice? Is there any drug of choice? Zinc is the drug of choice. 20 milligram per day into 15 days. The only drug of choice. Is there any role of antibiotics? No. What is the indication for antibiotic? Indication for antibiotic is Shigella, cholera. What else? Entamoeba, Giardia. Giardia. For Shigella, previous ciprofloxacin, but now it is replaced by cefixime. For cholera, azithromycin or doxycycline single dose. For both entamoeba and giardia, the drug of choice is metronidazole. Metronidazole. And finally, indication. So there are literally no antibiotics in acute diarrheal disease. When the child abdomen is distended, what is the diagnosis? When a child with diarrhea develops abdominal distension, what does it mean? The child develops hypokalemia. So you need potassium correction. When the child develops fast and deep breathing. What does it mean? A child with a diarrhea develops fast and deep breathing. What does it mean? It means acidotic breathing, otherwise known as Kussmaul breathing. Breathing. Very, very important. When the child urine output is reduced, it means renal shutdown. Renal shutdown. When the child develops cool peripheries, it means cardiac output is reduced. It means cardiac output is reduced. Finally, cardiac output is reduced. Finally, any child with acute diarrheal disease along with seizures, what are all the possibilities? 1. Hypoglycemia can be a possibility. 2. Hyponatremia. Hyponatremia is a possibility. 3. Even you can have hypocalcemia, which occurs when you give bicarb for acidosis. Hypocalcemia. 4. Cerebral venous thrombosis. Cerebral venous thrombosis. And finally, it can also be due to Shigella encephalopathy. Okay. Is there any role for loperamide? It is avoided, contraindicated, because it can produce paralytic ileus.